And good morning, everyone. Welcome. Thank you for joining us for our first webinar of the year, Opioids and Synthetics and What We Need to Know. Um, a few housekeeping items. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists who are claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for one EMT elective CEU. The Partnership for a Drug for New Jersey is approved by the Board of Certification Inc. to provide continuing education to athletic trainers, and this program is eligible for a maximum of one Category A hour or CEU. PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose, and all relevant financial relationships have been mitigated. If you wish to claim CME or CE credit, you must do so within 30 days from today's date. After that time, we will no longer be able to issue you credit. So please apply for that credit right away. We'll give you some information at the end of the webinar on how to do that. Today's webinar is jointly provided by the Partnership for a Drug for New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative and Community Responses, and the New Jersey Office of the Attorney General, as well as the Opioid Education Foundation of America. And once again, I thank them for their partnership, support, and collaboration on today's learning activity and throughout what will be a year-long learning series. And as we enter our sixth year of this learning series and have continued partnership and support from all those offices, I just want to once again thank them for all their support. Also, so pleased to welcome today's expert faculty. For those of you in New Jersey, you may remember our expert speaker today, Dr. Lewis Nelson, from his role as chair of the Department of Emergency Medicine and chief of the Division of Medicine, Toxicology, and Addiction Medicine at Rutgers, New Jersey Medical School in Newark. But now he is joining us from sunny Florida, and where he is the Dean and Chief of Health Affairs and Professor of Emergency Medicine and Medical Toxicology at the Charles E. Schmidt School College of Medicine at Florida Atlantic University in Boca Raton, Florida. So, Dr. Nelson, thank you so much for joining us today. Thank you for being with us, and I will turn the presentation over to you.
Well, thank you, Angela, and thank you to the partnership for having me here. I thought when I left New Jersey last year, I would never see anybody again. So it's really great that you invited me to come back. I still have deep roots in New Jersey. My family is up in the area, and I do feel the pain that everybody's going through there, even though you look out the window and that's a real picture. It's a real image of Palm Beach. It's actually quite chilly down here for Florida weather. So, it's in the 50s and you'd think that it was sub-zero the way people come out in hats and gloves. It's kind of cute in a way. I said to them, if it was 50 degrees in New Jersey today, people would be out in t-shirt and shorts and having doing the dance on the street. So I think I do again I do still and I do still keep in contact with a lot of my colleagues in New Jersey and Philadelphia and some of the other areas. So I am really glad to be able to come back and speak with you all again. So let me just get my slides going.
No, we definitely appreciate you being with us, and definitely echo your comments on the weather.
Yeah, but then I always remind my family that they could be in Minnesota. So,
That's absolutely
it's
correct.
all relative. I
It's all
could say
relevant.
that.
It's all
But
relevant.
anyway, yeah. So thanks, Angela, again. And as you said, I just left New Jersey a year ago, and I still feel very connected to what goes on there. And believe it or not, I mean, Florida is very different in many ways, and in many ways, it's very similar. I mean, and the substances we're seeing today really do cross across the entire United States in pockets, of course, and different regions have different issues. But there's some maps in here that'll show you sort of where New Jersey and Pennsylvania, Philly in particular, fit. A lot of the data I have comes from New York and Philadelphia, but some from New Jersey as well. And I think the idea. of the talk today is sort of catch everybody up on the state of the knowledge that we have about the drugs on the street, and as a clinician, really the way that we see people present to the emergency department and how we manage them. I realize there are several hundred people on the call. I was 650 plus. Um, Obviously, everybody's from a different walk of life, comes to this with a different perspective. Some are in the treatment world, some are in the law enforcement world, some are probably medical examiners, some are physicians. Each of you has your own perspective on things, which is great. And I always think about this as the kind of the blind man and the elephant, where we each touch a leg or a tail or a trunk, and we have our own perspective. But when we all sit together, we can come up with the fact that it's an elephant. And we do all work together. And I think it's very important that these kinds of discussions happen. I'll give you my perspective. Obviously, you may not even agree with what I have to say. I will say that some of what I think may be, surprising to you, and hopefully, when you think through it, it'll make a little bit of sense. At the end, we'll have time for Q&A, I hope, and some of you will express your opinions or ask questions. But understand that one of the things that makes our area of substance use, and particularly this topic, so interesting is that we all really come to it a little bit differently. You do hear, I now have a different job. I run a college of medicine. If you're ever in Boca and you want to come see Florida Atlantic, feel free to look me up. It's lovely, frankly, down here. Um, I have no financial disclosures. I don't work with pharma or any of those organizations, never have. And these are the objectives. I mean, I think they've been sent around, and they're pretty straightforward. Um, Again, just to get everybody on the same page, as a medical toxicologist in particular, I feel very um, deeply that words have meaning, and very simple concepts sometimes get missed. So if you don't mind, and you'll indulge me, I'd like to just talk about the word opioid. Remember, this is an opium poppy, right? When you scratch the surface with a razor blade, the latex leaks out, and out comes the opiates, right? And these are the only chemicals that we really can call opiates, and that would be morphine and codeine, right? There are a few others that come out that aren't opiates in structure, things like papaverine and noscapine. But really, morphine and codeine are really the only things that come out of the opium poppy, right? Those are opiates. Everything else is an opioid, right? And I think we have to be really specific that almost nothing we see today, fentanyl, heroin, all of those other drugs, all of them are opioids. And even though they're structurally very different when you look on a piece of paper, and I just put a little picture of an opioid up there, um, even though they might not look the same in two dimensions, at some level, they do fit in like a key into a lock on the opioid receptor, right? Now they sit on the receptor, and with the exception of naloxone, which has an opioid structure, they activate that receptor through secondary messengers and opening channels and generating cyclic AMP and other things inside of the cell, and they lead to the various clinical effects depending on where they're in your body and whether they're mu receptors or mu1, mu2, or kappa or whatever. Um, but really, it's hard to look at a chemical on a two-dimensional piece of paper and know whether or not it's going to bind and activate the opioid receptor. But all of these opioid agonists ultimately have the same effects, right? And this is really what's so important. And even drugs, even chemicals that we think of as non-opioids, like dextromethorphan, for example, it has many other receptor effects, and we'll talk about something towards the end, but it still has enough structural similarity in three dimensions to sit on the opioid receptor and stimulate it, which is why high doses of dextromethorphan have opioid-like effects. They have serotonergic effects and other things as well, as do some of the opioids. Of course, they can bind to serotonergic and dopaminergic receptors as well. So the consequences of any opioid use, and again, I'm going to just go my terminology. Some of you may use different terms, but I'll tell you, this are the terms I like to think about. And the word abuse, which we tend not to use, and we prefer the word use. There's some sort of stigma and pejorativeness to the word abuse, but again, that's perspective. Really means use for the feeling that the drug engenders. Right? Tolerance means a need for more opioid to get the same effect. right? People often confuse word tolerance with the word dependence, and they do tend to be linked because usually tolerance depends occur simultaneously, but not always. There are some chemicals which can do one and not the other, and vice versa. But the word dependence in the medical literature or the medical work means withdrawal upon cessation or reduction in dose, right? Sometimes in the psychiatric literature, dependence is conflated with the word addiction. I have a very much more specific meaning of the word addiction, and again, you may use different terms. I think the word hyperalgesia may be new to some of you, but it's probably the most important word you'll learn today from me. And it really means the heightened sensitivity to pain due to exposure, usually to an analgesic, in particular an opioid. And what that means is, and this is probably the genesis of the entire opioid crisis, is exposure to an opioid for pain makes the pain worse. In a way, tolerance and hyperalgesia are two sides of the same coin. And what I mean by that is that if you take an opioid for a while, and everybody knows this, 2, 3, 4 weeks, a month or two, you will start to need more. You will either need more because you're tolerant, which means that the effect of the drug wears off, or you will need more because you're hyperalgesic, which means the pain gets worse. Either way, it looks exactly the same clinically. One is kind of quote unquote blamed on the drug. The other is quote unquote blamed on the body, right? You have a rheostat in a way that says, I want to have X amount of pain. If I dull the pain, with an opioid, my body makes the pain worse. So you think about it that way, and that explains a lot about why taking pain meds for pain for a prolonged period of time, not of course for, post-operative or an injury or something like that, actually leads to worsening pain, and it's a vicious cycle. The word addiction means compulsive use despite harm, right? So any of the aforementioned models can lead to addiction, but harm is a key consequence of that, right? So if we think about addiction from a lot of things, whether it's, cigarettes, et cetera, nicotine, and there's harm involved, right? But remember, there are things that can lead to compulsive use, but don't necessarily lead to harm. And I like caffeine as an example. Many of you probably have caffeine dependence, right? If you don't drink a cup of coffee, you get a headache, right? And you use it compulsively. But it's hard to say you're addicted. I mean, we might joke around and say we're addicted, but the truth is there's no harm, right? At least in general. People aren't going to jail to get caffeine. People aren't, robbing banks to get caffeine, et cetera. And then, of course, overdose is both the act of taking too much and the consequences of taking too much. And, it's a little tricky with substance use, with illicit substances, because there's no true dose to say you took an overdose. So we usually really think about it as the act of taking too much. Either way, any of these consequences can lead to long-term use or opioid use disorder, which is defined, and you've all seen this, or you can find it. I don't expect you to read it, but recognize it's DSM classification. And regardless of the mechanism, if you take too much opioid, you will develop respiratory depression and you have a chance of dying. And that is a consequence of essentially any of these models. Now, people talk a lot about these waves of the opioid crisis. I don't want to go through this in any detail, but recognize that we really didn't think much about opioids before the late 90s. We just gave people some opioid for pain. And then, of course, we started thinking about, in the early 90s, we started thinking about the long-term use of opioids. And in the late 90s, we started thinking about extended release opioids, which led to that kind of that faint light blue line of an increase in deaths per 100,000 from the natural, meaning the opiates, and the semi-synthetics, meaning oxycodone, hydrocodone. They've basically taken the morphine backbone and added some functional groups to it. So it's a semi-synthetic. They're not made from scratch, but they're derivatized from the natural occurring morphine or codeine or one of the others. Of course, in 2010, we started to see heroin uh, price go down and availability go up, and we started to see an increase in heroin-related deaths. And then, of course, where it really all changed was in 2013-ish when we started to see an abundance of fentanyl. And you can see now that when we talk about the opioid crisis, we're really talking about a fentanyl crisis. And I'll even say fentanyls with a parenthetical S at the end because while fentanyl's still the 800-pound gorilla, there's a lot of other fentanyl derivatives out there. The one thing I want to point out, and I'll show you another slide in a moment, but people like to say that there's no more problem, no more crisis with prescription opioids. But if you look at that light blue or the faint blue line, or I guess I don't even know what color you call that, blue green, um, you can see that the number of prescription opioid related deaths is still fairly substantial, right? It's clearly dwarfed by fentanyl. But to say that there's no more problem associated with prescription opioids misses a bit of the forest for the trees. Right. So I want to be really clear that we still do have to address how we use opioids clinically. Nobody's suggesting we shouldn't use them, and I've never suggested that, but we do have to be judicious, and we still have some room to go with some of these things. But I will say that almost every medical specialty has stood up and done a nice job trying to curtail their unnecessary use. If you look at more recent data, and you can find this data and search it yourself in any way you want on the National Vital Statistics database, which you could just search NVSS and you'll find it, or NC, National Center for Health Statistics. But what you'll see, which is really interesting and very important, is that over the past year or two, the number of opioid-related deaths has dropped by about 30%, if not more. And you'll see that the number of prescription opioid related deaths has kind of stayed around the same. It's falling slowly. And the number of heroin related deaths, as you saw on the last slide, has really fallen off. And I think many of you know that our illicit quote unquote heroin supply now contains virtually no heroin. And it's basically all fentanyl, which comports very well with this data. Um, you'll see some numbers here for cocaine and others, and I'll talk a little bit more about that later. But I don't know if there are any forensic docs or medical examiners on the call, but there are always some judgments involved in how you classify somebody's cause of death. And we are seeing a rise in the number of cocaine and stimulant related deaths. But again, we'll talk about that a little bit more as we go forward. I do want to make a provocative statement, and this is a true statement. Fentanyl is no more dangerous than any other opioid, right? I think we have this boogeyman approach to fentanyl, but recognize that in clinical medicine, we use fentanyl all the time. And in fact, we could use carfentanil or or any of the fentanyls safely, right? If you dose it correctly. And I think that's a really important concept that is only becoming increasingly important nowadays as we start to see these ultra potent drugs. I remember dose is a number of milligrams of the substance taken. We know what the right dose is for acetaminophen and for amoxicillin and for morphine and for fentanyl and for fluorofentanyl and for any fentanyl, right? We know that we can give you the right dose as long as we adjust it for the potency. And the potency is a factor that determines how many milligrams or micrograms and nanograms of drug you have to take per kilogram to have a specific effect. So if I know I want to give you a pain dose of morphine, I'm going to give you 10 milligrams. If I want to give you a pain dose of fentanyl, I'm going to give you 50 micrograms or 100 micrograms, right? I'm going to dose it properly. If I gave you 10 milligrams of fentanyl, you would die, right? It's because it's more potent. But if we dose it properly, it's perfectly safe. This is a slide many of you probably, or photo many of you have probably seen, and it really shows what's considered to be a lethal dose of three different opioids. Or maybe you could see in the image that it takes a lot more heroin to get an equally effective or an equally lethal dose of fentanyl, and even more so fentanyl being around 100-fold more or less potent than carfentanil. You can see that it takes barely an invisible amount of carfentanil to lead to immediate consequences. So understanding dose and potency is important. Don't just think because there's ultra potent opioids on the street per se, it's a problem. I mean, it is a problem, but it's a problem because you have no idea how much you're taking, right? Whether you're taking a counterfeit pill or you're buying a bag on the street or whatever mechanism you're using for your drugs, it's not the drug itself that's a problem. It's the fact that there's about no quality control on any of these things. If pharma made carfentanil for human consumption or for human use, it would be perfectly safe because we know how to dose it. So I just want to make sure that everybody's really clear about that, that we don't need to vilify the drug. It's really the way the drug is being used. That's the problem. Now recognize that there are tons dozens of different fentanyls out there. And increasingly, we're finding more fentanyl-like drugs like the nitazines, as an example you'll see here, which shows you some of the structures. And, to people that are very chemically minded, these structures might carry some meaning to you. For most people, they just look like a bunch of rings and nitrogens and things like that. But remember, even though in two dimensions, you may have some trouble equating them, if you're not, particularly if you're not medicinally chemically minded, they do in three dimensions fold properly in such a way that they sit on the receptor and activate it. Now, each of these has their own potency, which means each of these has their own proper dosing, and really none of these are used in humans for clinical use. So, for the most part, we have about no data that we could rely on for any of them, right? That's what makes them dangerous. So somebody's creating them, somebody's putting them into our drug supply, and people are using them. And since the drug supply, even when it's tried to be appropriately made, is still going to have large amounts of variability, dose to dose, bag to bag, pill to pill, sample to sample. Right? That's just the nature of how drugs are made outside of a pharmaceutical company. So, but recognize if you look at the DEA website, this forensic laboratory site, there's lots of information. I can't possibly go through all of this and give you details about anything, but you'll see that in various parts of the country, there's different prevalences of different nizines, different fentanyl derivatives, but also recognize that there's still very low prevalences compared to the main drug fentanyl, right? And as I mentioned earlier, there's essentially no heroin in almost any of these. And of course, there are other adulterants mixed in, we'll talk about in a few moments. So my favorite philosopher or pharmacist was Paracelsus. He lived back, you can see, in the early 1500s. Um, his fundamental statement that dose makes the poison is exactly right, right? And we know in medical toxicology that there is nothing that is not poisonous. It's all about taking a sufficient dose to lead to consequences. But recognize that back when Paracelsus said that, there was no such thing as potency because you didn't even have you didn't even have heroin, you didn't have morphine, all you had was opium, for example. So we didn't really have to think much about potency because dose was dose. But now, because of potency, we have to be really thoughtful when we say the word dose. Let's talk a little bit about xylazine and medetomidine, right? People conflate them, and there's a lot of similarities between them, but they really do separate out at some level. They're both used as veterinary sedatives. They both work as alpha-2 adrenergic agonists. The alpha-2 receptor is a presynaptic receptor in neurons in your brain, in various parts of your brain. Um, they are similar to clonidine. A lot of people like to, again, relate the two. But clonidine binds more to the imidazoline receptor than it does to the alpha-2 receptor. Now, those two receptors are linked in neurons, and structurally similar chemicals bind to both of them in various ways. So if you take enough clonidine, you will become sedate, but in the process, you will get quite bradycardic, your heart rate will go down, and your blood pressure will fall, right? With the alpha-2 agonists like xylazine and medetomidine, they tend to be much more sedating, which is alpha-2, and have much fewer bradycardic and hemodynamic effects, right? We don't have access to xylazine and medetomidine in clinical practice, so many people use clonidine when they want to treat people who use xylazine or medetomidine, and it's fine, but recognize that even though they are similar in structure and have similar related effects on these two receptor classes, they do bind differentially to the imidazoline receptor and the alpha-2 receptor. So xylazine and medetomidine are very good sedatives. They have minimal respiratory depression. And that's a very important fact. And we know that because we use dexmedetomidine, which is one of the isomers, or the enantiomers, I should say, of medetomidine, which is racemic. And we know that it is a great sedative with minimal hemodynamic and respiratory effects. Obviously, with anything, if you go up in dose, you're going to see other things, but at the conventionally used doses, it's a pretty reliable drug as a sedative. Importantly, medetomidine and xylazine are not opioids, and they are not reversed by naloxone. I'm sure everybody on this call knows that, but it's probably worth repeating. Importantly, um, and this is where we start to get into some of the trickery or the trickiness, I should say, of determining cause of death. A nice piece published in the CDC on the left, and there's a corresponding image on the right is the epidemiology of it. But if you look at the le on the leftward graph, you'll see that over time, the number of fentanyl involved deaths in which xylene was detected rose pretty steadily, leading some to suggest that xylazine was causative in the death, right? And that was often messaged. And in fact, the word in one of these curves is co-involved. And this is where, again, it becomes tricky when a medical examiner is trying to determine cause of death and they have xylazine and opioid, fentanyl in this case. How do they know whether the fentanyl led to death or the xylazine led to death? We've spent a lot of time in our collaborative worlds and separately trying to figure that out. But I do think that almost all of these cases, xylazine played a minimal contribution, and the fentanyl was the 800-pound gorilla leading to the cause of death. And we know that from clinical practice. And obviously, we may see things a little bit differently, but I do believe, and I think that there's enough data to suggest, and I'll show you some of it, that xylazine is probably not contributory to opioid-related deaths. The reason those two curves are going up and the reason there's more xylazine detected in fentanyl decedents is because there's more xylazine in the drug supply, right? Not because the xylazine like that. The number of decedents didn't go up. The number of decedents with xylazine went up. Right? Just an important, subtle semantic difference, perhaps. But we do have to be careful how we message this. And again, I'm not here to protect xylazine or medetomidine, but I also don't think we need to inappropriately message or vilify them. Some of the messaging that came out was a little bit off base, right? When you think, you think about xylazine is this making fentanyl more deadly. It's not at all clear that that happened. I think fentanyl is deadly enough without adding xylazine. And you could think back through some of these as you go forward. But just to show you, here's just one nice paper from Jen Love at Mount Sinai, New York City, who showed that comparing patients in their emergency department who had xylazine positivity, who were fentanyl overdose patients, who had xylazine positivity versus those without xylazine, they actually had better outcomes, right? In almost every metric. Some were reached statistical significance just because of this relatively small population, but fewer of them actually wound up having cardiac arrest. Their coma was shorter lived than it was in those who didn't have xylazine. And there's probably a reason for this, right? By adding xylazine, which is a sedative, to the mix, they actually were able to reduce the amount of fentanyl in the product that the patients were using, right? Which means that they were actually taking a less problematic opioid because there's less of it in the product that they're using. On the right, you'll see a graph from Ohio. The blue line shows the amount of fatalities that had fentanyl. Um, and you can see that as the number of fatalities with fentanyl, I'm sorry, the fatalities that had xylazine, fentanyl fatalities that had xylazine, as that number went up, the actual number of fentanyl fatalities went down, right? Suggesting again a quote unquote protective effect of xylazine. Now, I don't think xylazine protects. Don't misquote that. I don't. Some have suggested that xylazine might have an antagonistic effect on the opioid receptor. I don't think there's any data to suggest that. I think it's a dose issue. Adding xylazine to the product reduces the amount of fentanyl that has to be added. It's a cutting agent, it's a bulking agent, it's in there to make the drug usable. Remember, fentanyl, the amount it takes for you to use to get high is nearly invisible, very hard to use, so they have to add a bulking agent. What you're seeing now in our region, in the New York, New Jersey, and Philadelphia region, is a near fall off in the amount of xylazine that was in the product, and an increase in the amount of medetomidine. I think we've all experienced that in our patient populations, and certainly Epi shows that. And it's the same that you'll see in New York on the right. Over a year and a half period, they went from no medetomidine to a third of the samples. and the amount of xylazine has fallen from half the samples to 40% of the samples. So it's going down as well. The amount of fentanyl, by the way, that they show in this nice brief has really more or less stayed about the same, and that hasn't changed. It's gone down, it wavers a little bit, and now, but more or less it's been above 90% um, for quite a while now. In this image, you can read the top if you like, but the image that you see here from CFSRE, which is an organization based in the Philadelphia area, you could see that methamphetamine is spread across the state, and we have it down here in Florida. We see it in all the tri-state area. Where we are in New Jersey, you can see it also out in the rest of the country. And this is detection, right? It's unclear how much is in the product. It's unclear how much consequence there is from it, but it's simply detection either in biological specimens from patients or decedents or in the actual product that's being tested, right? It does. What's an interesting phenomenon that you could see related to the change from xylazine to medetomidine is the amount of xylazine wounds, which we were talking about for several years, and how horrible they were, has plummeted, right? And it's always been a question about whether or not the xylazine did it, or the drug use did it, or if there was something else in the drug supply that did it. It seems that once medetomidine started hitting the scene and xylazine started falling off, it kind of firmed up the fact that xylazine might have actually been the culprit, right? Unless there was something else in the xylazine um, um, laced fentanyl, xylazine might have actually been the cause of it. It's hard to explain why. Xylazine is a little bit of a vasoconstrictor. It had some other potential mechanisms, but medetomidine should have some of those same effects. So it's a little bit unclear. The good news is the number of skin and soft tissue infection, the wounds that we would see, has really fallen dramatically in the Philadelphia area, and that's obviously a good thing. But what has happened, unfortunately, at the same time that medetomidine came into existence, is what was kind of a questionable withdrawal syndrome related to xylazine. It was a bit more of a discontinuation syndrome. It didn't really have a very predictable effect. It was very easily conflated with opioid withdrawal. It didn't really look that different. Maybe it was a little bit more severe. Has changed into something that is a dramatically more impressive withdrawal syndrome. So for people whose medetomidine is clearly an issue. And you'll see a nice piece from our colleagues down in Philadelphia that really explained what they were seeing recently when it came to medetomidine withdrawal. And my understanding now is that they are seeing several patients a day still in the Philadelphia hospitals. Somebody might be on the call with severe withdrawal, severe enough. And if you look at the clinical criteria, where 90% of them, the bottom line under admitted to intensive care, are admitted to the ICU. That's pretty severe withdrawal. I mean, opiate withdrawal patients rarely need ICU care. Alcohol withdrawal patients more so, but even then, 90% would be just an unheard of number. So clearly, the chronic use of medetomidine leads to a dependence and a withdrawal syndrome that is highly consequential. There are a lot of other drugs in the drug supply that we think about, but I just want to point out, as I was alluding to earlier, that we have to be really careful about how we adjudicate cause of death. And again, I'm not here to tell medical examiners their job. We're forensic toxicologists. I do think, though, that when we think about things like stimulants, stimulant-related deaths are pretty uncommon, right? You could have a big, massive MI, myocardial infarction, heart attack. You'd have a big stroke. You could get psychomotor agitation, hyperthermic, and die. But the mechanism of death of a stimulant is very different than an opioid. Opioids produce predictable death. The more I give you, the less you breathe. At some point, you're not breathing enough and you die, right? Cocaine, stimulants, the psychostimulants are amphetamines and amphetamine derivatives and other substances along those lines. But functionally, the reasons they kill you are situational. Hyperthermia, rhabdomyolysis, things that are related to that. And so if you look just pick one of these, pick C, and just look at the cocaine and no opioids dotted line at the bottom, is very, very few. So almost all of the cocaine opioid related deaths, almost all the cocaine related have opioid mixed in with them. Because opioids, going back to my original description with xylazine, opioids are the formative issue here, not the stimulant. So again, there's more cocaine deaths There's more stimulant deaths in large part because there's more cocaine and stimulants in the drug supply. And you could say the same about the local anesthetics on the right? You can look at the list of local anesthetics that have been in our drug supply, particularly our cocaine supply, for as long as there's been cocaine sold on the streets of our cities, right? It's a local anesthetic. It feels numbing when you put it on your gums. You could see why people use it. It is increasingly prevalent. The clinical attributes that people suggest are related to these local anesthetics don't really make sense, right? When we see local anesthetic toxicity, it's almost always from intravenous use from very high doses. People do have coma and seizures and cardiac arrest. At the doses you could possibly take in through intranasal use or smoking, which is the way that the majority of our opioids are used today, it would be hard for me to imagine how you can get anything more than maybe a little bit of a tingling. But certainly thinking local anesthetic, systemic toxicity last, or a seizure, it would be very, very hard to imagine. Remember, all these dots are just prevalence issues. They have nothing, they don't tell you how much lidocaine or procaine or any of these are actually in the drug. It would take a large amount used pretty quickly and probably IV to lead to any significant clinical consequences. Undoubtedly, it's there. I won't dispute that. Whether or not there's clinical consequence to it is unclear. I still think the problem with fentanyl laced anything is the fentanyl. Right? Again, benzos, same issue. There's a lot of benzos out there. You can see bromazolam is still our by far most highly prevalent one, but there's dozens of others. And the clinical consequence of this, just like perhaps with xylazine or medetomidine, is that patients are more sedate than they would otherwise be. And that's really important because naloxone does not reverse the effects of xylazine or metamine or benzodiazepines or light or local anesthetics for that matter. Yet everybody knows that it's a drug of choice for people who take um, fentanyl or opioid overdoses now because we're treating the fentanyl. We're not treating the xylazine. We're not treating the metamine. Once you reverse that fentanyl, the patient's going to breathe. Right? Xylazine, benzos, they are not sufficiently respiratory depressant to lead to any consequences. So why don't people wake up after naloxone? Well, remember, before I even move on to the answer, we should not be looking at waking up as the endpoint. We should be looking at breathing as the endpoint. Because if people don't wake up, I kind of like that because it means you could bring them to the emergency department. And I could take care of them, right? If you give them naloxone and they wake up, they're going to leave. They're going to go out and try to procure and use more drug. So I like the idea of not waking up, but I like the idea even more so that they're breathing. So they don't wake up because they haven't breathed in a while. Their brain is hypoxic. They have high blood carbon dioxide levels called hypercarbia. They have adulterants or alcohol or something else. Maybe there's a medical condition like trauma or an infection. It could be completely unrelated to anything. The implication of this, it's really important, is if they're breathing, and you don't have to breathe a lot. You breathe 4 or 5 times a minute, you're going to be fine as long as you're going to ultimately get care. You don't want to do that forever. Um, that is really important. I don't like to hear that somebody got 8 doses of intranasal naloxone, or they're, doing things to the patients that they don't need to do to wake them up. Waking up is not the endpoint. If they don't wake up for naloxone, but they're breathing, that's fine. Opioid dose or opioid potency is rarely a cause of naloxone failure, right? Naloxone is incredibly potent. The ability to knock off just a small amount of opioid from that receptor is all that's required to make the patient breathe. Yes, it's a competitive antagonism. You could take enough of an opioid that naloxone won't work, but that is not very common. That would mean that somebody got an inadvertent batch of an opioid that was made to be ultra intoxicating. That's not typically how drug sales works, right? You don't try to hurt your clientele, and there could be mistakes, could be hotspots and other things, but in general, it's not a problem linked to the opioid. So what do we need to do? I mean, we have to continue on using naloxone for sure. I'm not a huge fan of nalmefene. I don't know that it has a large clinical use yet, at least to precipitated withdrawal that lasts for quite a while, unlike naloxone, which leads to precipitated withdrawal in many patients, but it's brief. More data needs to be collected before we could really look at nalmefene or the high dose naloxone preparations or multiple doses of naloxone. A dose or two is usually enough. We should think about updating our pathways for patients who don't respond completely. As I kind of mentioned, we should get them to the emergency department, get EMS involved. We should educate people about how to breathe for them if they're willing to do it. I mean, many of us aren't going to put our mouths on people we don't know, but at the very least, we could put them in the recovery position. We can activate EMS, um, et cetera. We have to keep naloxone in our pockets and be ready to do it. I think about harm reduction, obviously, which begins and ends to some extent with education. If you don't know about it, it's not going to work. And you all, I'm sure, at some level in your life, live all of these things. The one thing I'll tell you that may be controversial is I don't believe that fentanyl test strips are helpful at all because every drug supply now has fentanyl in it. So you're going to test, you're going to find it. What are you going to do? Right? At least if you're talking about opioids. If you're testing your cocaine supplier, your methamphetamine supplier with fentanyl test strips, it does make some sense, right? But to test fentanyl with a fentanyl test strip isn't going to be very productive. Right. Some of these are controversial, like safe consumption sites, et cetera. Obviously, we look a lot. I spent a lot of my time in addiction medicine looking for ways to get people connected to long-term care. I'm an emergency physician. I like to start people on buprenorphine. I like to give them a dose of methanol. I like to get them connected in my other life as an addiction physician. I like to get them into our and get them moving. I think that's very important. And that's one of the reasons I like people not to wake up because then they'll come to me. Because if they wake up, they're probably not going to come to me. We don't have mandatory transport in most of the state. So people are going to just want to leave. Right? Of course, we need to track um, our overdose withdrawal presentations. We need good data from the health departments. Philadelphia has done a particularly good job at trying to track this information. We need to look at drug checking to share our epi so we know what's in the drug supply. It doesn't lead to direct anything. You're right. No patient's getting a drug. None of our patients are going to, we're never going to know if our patient's using any specific nitazene or fentanyl because we don't have the ability to test in real time. But it's kind of nice to know what's in the environment, what people might be exposed to. Although technically, clinically, from my perspective, it doesn't really matter. I'm going to give them naloxone. I'm going to breathe for them. I'm going to do those things regardless which opioid they took, right? But it's kind of nice to have some good sense of what's out there. And then, of course, we need to share information across borders, and I think we do an okay job with that. We could do a little bit better, as we always could. But I worked closely with the New Jersey Poison Center when I was there, NJ Pies. I know that we're in communication a lot with the folks in Philly and in New York, and the MEs probably share data, et cetera. So I think, and I know the law enforcement services do as well, having worked a little with them when I was in New Jersey. I want to spend a minute talking about a different product that we're seeing now. Many people are familiar with kratom or mitragynor or mitragynor speciosa, which is a plant that grows in Southeast Asia and contains a chemical called mitragynine or mitragynine, which has lots of uses, right? And it's claimed to be used for pain and anxiety and fatigue, and many people use it to treat their opioid withdrawal and even try to manage their opioid use disorder with it. It is not FDA approved. It's unregulated. It falls under the Dietary Supplements Health and Education Act, the SHEA, right? An act from the early 90s that prevented the FDA from regulating natural products. This kind of straddles kind of a funny line about that, and given its uses, but again, it has never really been formally FDA approved, and it is sold in, lots of venues, not, I mean, it could be sold in pharmacies, but it's not sold behind the counter at a pharmacy. It might be sold with dietary supplements. You'll find it in smoke shops and head shops and places like that. Um, I think we have a good sense of how that works. And you can see the patchwork of regulations around the country is what that graphic shows. But what we are seeing now is a new product called 7-hydroxy or 7-hydroxymitragynine, um, which is a product that occurs in a very small level in natural kratom, about 2%. Um, but it can be concentrated and it can be synthesized, right? Kind of like when we think about some of the cannabinoids, right? Where we think about Delta 9 versus Delta 10, et cetera, where they, can change the the chemical ever so slightly, in this case by adding a hydroxyl group, in that case by moving a double bond in the delta 10. Um, but what happens when you do that is you create a molecule that has a much higher mu receptor agonism, about tenfold higher, and that makes it more potent. So if you're used to using a certain amount of mitragynine and now you're using hydroxy, 7-hydroxymitragynine, you're going to be taking a drug that's tenfold more potent, right? It's often sold standalone as 7-hydroxy products in gummies and in powders and in drinks and in gas stations and again smoke shops and places like that. It's sometimes even added to kratom extracts. It's much more concerning. And the FDA recently actually came out with a paper kind of extolling the risks of this drug. And I tend to agree with it because it's an unknown. It's taking us down that same road that we saw when we went to these potent fentanyl derivatives, and it's a bit of an unknown. And it's more dangerous because we don't know what we're taking. I think we understood mitragynine. What we're really seeing, though, that's very consequential is a much more severe withdrawal syndrome, right? And again, management of overdose on the left, management of withdrawal on the right. Basically, you manage them just like they're opioids because it is essentially an opioid, right? It might have some other receptor effects, a little serotonin, a little dopamine, but overall, opioids are, again, the 800-pound gorilla. So I'm going to end here. I'll finish up and I'll see if there's any questions that anybody has. But just, remember, an opioid is an opioid. It's really the potency that matters. And if you dose to the proper potency, you're going to be fine. But knowing what you're getting is the problem. Right? We talked a little about the fact that there is still an iatrogenic component to the opioid crisis, but clearly it's a fentanyl, nitazene, et cetera, problem. We talked about naloxone, but again, naloxone can save your life, or at least it can prevent you from dying. But to really prevent somebody from surviving long term, you need to get them into treatment. Whether you buprenorphine, methadone, and I know a lot of people out there still believe in abstinence-based treatments, and you know what? I'll take anything if people go into treatment. I tend to believe in medications for opioid use disorder, but people need to get into treatment. We talked about xylazine and metamidine. Xylazine is essentially gone. Metamidine is a new kid on the block. Metamidine is going to be gone in a year, and we're going to have something else, right? Which is one of the reasons I don't make a big deal about developing tests and treatments for it, because we know we don't need a reversal agent, right? It's not an issue because it's going to go away anyway. But reversing it doesn't help because there's really no critical consequence to xylazine and metamidine. They're not potent respiratory depressants. Reverse them, reverse the fentanyl. And then we talked about kratom. So I'll leave you with my contact information here. And Angela, I'm done with my talk. And we have a few minutes if anybody has any questions.
Absolutely. Thank you so much. So much great information. And yes, if anyone has any questions, you can put them in the chat, and we can get to them. But we did have a question that was sent to us prior to the webinar, and that was a question on naloxone. And the question is, how safe is it for children, teens, and seniors, more of the people who might be at risk? Could you speak to that?
How safe is naloxone in those populations who are
Yes.
opioid using?
Yes, if
Or
there's an exposure or
no,
particularly like
naloxone's completely safe. I mean, look, I just said that everything is toxic if you take enough of it. So I'm going to be eating my words here. But I think it would be very hard to do damage with naloxone. I mean, if you don't have an opioid on board, it's not going to do much to you. There are some, concerns, highly trained athletes, for example, who live on endogenous opioids, right? The endorphins. When they get naloxone, they sometimes feel a little dysphoric and unhappy. But for most of us who are not highly trained athletes, there's going to be minimal consequence. So I wouldn't really worry about it. Now, of course, if a child or an older person overdoses on an opioid, and needs naloxone, they should get it. I mean, it's 100% safe, functional, and useful. So I wouldn't think twice about it. But we know there's been a lot of studies for other reasons. Back in the 70s and 80s, we looked at high dose naloxone in patients with spinal cord injury, thinking that there was an endogenous opioid component to some of the consequences related to the spinal cord. People getting milligrams, grams, literally grams of naloxone, and we're fine. There were no adverse consequences, so I would not worry about it. Long answer. Um,
Long answer, but necessary information, right? I
yeah, no,
think.
good question. I did see a question that I wanted to address, which is why are kratom and 7-hydroxy on the market? Again, it goes back to DSHEA, right, which has to do with how the FDA can regulate um, dietary supplements, right? And for example, technically, cannabis could have been a dietary supplement, although it was scheduled before the dietary supplements regulations came out. They can pull drugs from the market if they're unsafe, but there has to be a real effort to get that done. And there just hasn't been that put forward. DEA can schedule it, right, and make it illegal, but it hasn't done that. So it is a little tricky how these regulations occur. DEA is spending a lot of time scheduling other very harmful compounds, but just one of these loopholes in the law that kratom can exist as a dietary supplement until it's proven to be dangerous. And somebody could do that, and theoretically, FDA would probably ban it.
No, absolutely. Um, could you talk about briefly just any long-term effects of xylazine? I know you said it's kind of on its way out and there's new. Anything that particularly I think those people who are in the awareness field need to know about.
Yeah, there's no information really to speak of. I mean, I would kind of use xylazine like we view most other sedatives, which is if you get acute doses of it, you become sedate, and then when you wake up, you're back to normal, right? If you look at a benzodiazepine or any of these others, obviously, if you use lots and lots and lots of it, you might develop a dependence to it, and you might have withdrawal syndrome. So it's not shocking that there's some xylazine withdrawal. It's just not a fulminant disease, unlike medetomidine withdrawal, which is a pretty significant, consequential syndrome. Um, Wounds notwithstanding, which obviously have long-term consequences, there's probably no reason to think that once you've stopped using the xylazine and you've gone through whatever, withdrawal phase you need to go through, you're probably back to baseline. And that's the same as alcohol or the same as benzodiazepines, right? And if you don't continue the long-term use, you should get back to pretty much your normal baseline.
All right, thanks. And this just came in the chat. I think you addressed it, but can naloxone reverse the scrotum use or overdose or symptoms?
Absolutely. Mitragynine and 7-hydroxy are opioid, at least in good part. Just like dextromethorphan I mentioned earlier, they would they would absolutely be reversible. It would only reverse the opioid effect. So if there are other effects, you wouldn't expect them to be reversed. So, for example, mitragynine might have some serotonergic effects, which are not particularly concerning. Those would not be affected by an opioid antagonist. But naloxone, pretty much paradoxically, the only opioid that naloxone does not have uh, a strong ability to reverse is buprenorphine, right? But buprenorphine is a very unique opioid because it's not a full agonist, it's a partial agonist. It has incredibly high affinity for the receptor. But the good news is, even in overdose, it produces minimal respiratory depression because it's a partial agonist. So there's very little limited need to ever reverse somebody that's taken a big dose of buprenorphine, and people don't tend to overdose on buprenorphine anyway.
I know we have a lot of naloxone questions in the chat. Pregnant mother is overdosing and given naloxone. Are there chances of reversal for the fetus? Um,
100%. I mean, look, if you don't save the mom, the kid has no chance, and the mom has to breathe, right? There has been this theoretical risk associated with naloxone and fetal development, which comes mostly from animal models and with chronic use. It's hard to believe in any way that a single dose of naloxone, even a few doses of naloxone, is going to have any adverse effect on a child. Hypoxia in the mother will. 100% for sure. So reversing the mother is an absolute requirement in my mind. It's not even something to be debated. Withdrawal in the mom could lead to some fetal disturbance. So I like to be careful. I always like to be cautious with my naloxone administration. The good news is intranasal naloxone, just because of the vicissitudes of its absorption through the mucosa, et cetera, it doesn't bolus them the way intravenous use does. So withdrawal tends to be more muted with intranasal use of naloxone anyway compared to intravenous use. So if you have the option of giving it intranasally, I think that's the best way to do it.
All right, thanks. I know we're coming to the end of our time. We have about 3 more minutes. I just want to make note there's information on the screen about how to apply for credit. But Dr. Nelson, I just want to give you a moment. Um, I know you talked about in the beginning about the fact that this is a conversation we can need to continue to have about opioids. But what are your final thoughts to leave us with today? Most important things that we can take with us through through the work that we do.
Well, I'll go back to what I said at the beginning. We each have a role. I mean, for those that are in law enforcement, getting drugs off the street. For those of us that are in emergency departments and pre-hospital care, keeping people alive. For those of us in long-term treatment, doing that, right? Getting these people to stay as best they can off of substance use, right? And we recognize the difficulties in all of our roles. But look, the people who do epi work and do forensic work, they feed right into the elephant, and they play a big part in helping us understand what we need to do. Identifying clusters, so to speak, or hot spots is really important. The public health folks, how do you message that? It's tricky, right? Sometimes you're resistant to telling people about quote unquote good drugs on the street or bad drugs on the street because in some warped way people like those. They think that's great. But yet on the other hand, if they don't know that there's dangerous drug on the street, they're going to get in trouble. So when and I've been in public health world and I recognize how tricky it is to message these things, and good luck to you that are doing that now because it's hard. But we do believe that knowledge is power, so we do tend to fall on the side of messaging, but it's hard. But anyway, so I think that everybody talking these meetings, these events, the collaborations we have are so absolutely critical to addressing this issue.
No, I agree with you. And so, once again, I thank you for your continued collaboration. I think we've worked together since 2017 or 2018, and really appreciative of that and all of the knowledge that you share. And in such a great way, as you'll see in the chat, you have a lot of feedback on your presentation, Sal. So we really appreciate that. And to all of you who joined us today, as Dr. Nelson mentioned, we all have a role. And it's always great to be equipped with the most information possible, right, to do the work that we do. And so I thank all of you for joining us today and continuing to join us in these webinars. There's information on the screen once again on how to apply for your continuing education credits. And I hope that you'll consider joining us for our February webinar, which we will discuss opioids in pregnancy and neonatal abstinence syndrome. So hope that you can join us for that. We're going to have some great experts on the topic for that webinar as well. But once again, thank you, Dr. Nelson. Thank you to everyone who's with us. And I wish everyone a good end of January and looking forward to seeing you in February. So thanks, everybody. Have a good day.
Thank you again. Stay
Thanks.
warm, everybody.
Yes, you too.